So you mentioned a new technology. How is that opening up new avenues into fluid management?
Well, I think, going back to why we give fluid, we've always given fluid to expand circulating blood volume and to support perfusion and circulation. And when we give fluid, the question we've always been asking is, what will the heart do with it? Will the heart actually improve cardiac output? Will it improve perfusion? And if you go back to the earlier days of CVP, even earlier days of echo, what we've always been using those technologies to predict is, what do we think is going to happen when we give fluid? Well, with the advent of stroke volume and cardiac output, non-invasive at the bedside, we no longer have to guess. Finally, after hundreds of years of guessing, we have the data right in front of us. We can actually look and see whether or not the heart responds to fluid. And that is very exciting. That just opens up a whole new window into the physiology and the understanding of fluid management. We've never had that before.
So you also mentioned seeing new physiology. So what do you mean by that?
Well, we're seeing a couple things. I think one of the things that's most striking, I think when clinicians give fluid, they believe that it's beneficial and they want to see it expand the circulating blood volume. When you actually look whether or not stroke volume increases when you give fluid, you only see that in about half of patients. That's interesting because you see that across multiple clinical settings, whether you're in the emergency room, whether you're in the operating room, whether you're in the ICU. You also see it across the technology. So this isn't technology specific or it's not setting specific. This is this natural physiology of preload dependence, fluid responsiveness. It is much more variable than what we have previously, I think, thought as clinicians. It's actually fairly challenging or provocative for clinicians to see this.
Right, so you're saying only half the time.
That's right. So multiple studies have shown, looking at even hemodynamically unstable patients, hypotensive patients, only about half of them will respond to fluid by improving their cardiac output.
And that's powerful because today we can see this at the bedside, actually.
Well, we can see this, and then you couple that with the understanding of the risks of volume overload. If you're not getting fluid expansion, if you're not getting improvement in cardiac output, the additional fluid that you're giving is simply going into the lungs or into the kidneys or into the liver, into the gut, and increasing fluid load and really not serving a benefit. In fact, may be very harmful.
Interesting. So are there other ways then beside cardiac output that gives us better insight into what's happening with the patient?
Yeah, it's a great question. I think not only are we seeing the whole concept of fluid responsiveness, but this is actually the other value that I think we're seeing when we start using stroke volume and cardiac output at the bedside to guide clinical management. Mm-hmm. We're seeing actually physiology that we've known for a long time. Blood pressure has been easy to measure. We've measured it since the late 1800s, early 1900s. So we've had it around for a really, really long time. And blood pressure is easy to manage, and we know how to use it. But blood pressure is actually not a great indicator for perfusion because we know that vascular resistance and other things come to play to maintain blood pressure. Meanwhile, flow underneath blood pressure can be highly altered. If you think about patients that are critically ill in the ICU on very high doses of vasopressor, you may have an okay pressure, but your flow, your perfusion underneath that is very limited. One of the earliest studies, and I love this study, it's a great study, Barcroft did this in 1944 with, I think it was 7 Irish medical students. And what they did was they got these medical students to sign up for this study. It's much better to be a medical student today, I think, than in 1944. But back in 1944, the deal was this. They were going to bleed them until they fainted.
Nice.
Okay? Yes, very nice.
Okay.
Easy study to do. And they measured cardiac output while they were removing blood volume from them. And sure enough, what you saw was blood pressure held flat, literally until the very end, until they fainted, and then it fell off a cliff.
Okay.
But if you were actually looking at cardiac output, you could see it actually fall linearly early. So cardiac output, we know, is an early indicator of intravascular loss, intravascular perfusion problems. Another study that's more recently done on this, Cavertino looked at this, I think it was in 2004, and recreated this in Army Rangers. He didn't bleed them, but what he did was he put them in a lower body negative pressure suit. So basically acutely removed blood volume from the central circulation into the legs. And so it's a very good model for acute blood loss and sequestering preload. And sure enough, what they see there is quite fascinating. Again, known to us as clinicians, we don't sort of think about it on a day-to-day basis. But blood pressure up to about 1.5 liters of acute blood loss remained fairly stable. It didn't really change much, certainly not in the range that you would think clinically. It went from about 130 down to 115. And we see that all the time clinically. We don't react to it. But if you looked at the physiology underneath this, you see stroke volume fall dramatically from about 130 down to about 39, linearly, okay? You see cardiac output come down too, and cardiac output, of course, is mitigated because heart rate goes up a little bit. So stroke volume has the biggest change. And then, of course, vascular resistance is compensating to keep the blood pressure up. So you have all this physiology occurring underneath a very normal blood pressure. So I think the other value that these technologies bring is we have better views and better understanding of perfusion than with blood pressure alone. So actually, when we're monitoring people with these technologies, we're probably intervening earlier than we would with blood pressure, which I think also brings value.
Yeah, because what I hear you saying that the studies and the data is showing us is that blood pressure is really a late indicator of a worsening or developing perfusion problem, whereas stroke volume and cardiac output are really changing first.
Absolutely. And I would even go further than that, because I think when we think about how we measure and think about perfusion as clinicians, blood pressure we also use things like urine output, we use things like mentation, we use things like ECG, looking at cardiac function. All of those, and lactate for that matter, all of those are very, very late indicators. And certainly blood pressure is probably better than some of those, but those are all very late indicators of after organ damages or the organs are already struggling to deal with the lack of perfusion. So looking at stroke volume, trending stroke volume, really lets us see around the corner of blood pressure that we haven't been able to do before.
Nice, I like that. So what's the evidence then that this approach actually works?
This is where it gets very interesting and very exciting. There's evidence really in multiple fields that show this repetitively as you start to look at it.